Hey guys, so today I'm going to talk about how to survive your surgery rotation specifically for medical students. And I'm going to break it down into the different clinical settings in which you're going to be working. So, the overarching philosophy that you should have throughout the entire rotation is three words: being um, affable, being available, and being able. The three A's in that order. Um, And basically, what this is saying is that if nothing else, you want to be pleasant to work with, you want to be respectful, you want to be professional. Then, after that, you want to be available, meaning you say and keep your promises when you're going to show up, when you're expected to be there, the schedule you're assigned, the cases you're assigned. You're always there. Wherever the team wants you or assigns you, you are there as assigned. You're always available, and the team knows where you are. And then finally, the at least for medical students, the least important piece of this three A's aphorism is to be able. Once you've been taught something, or if you've been instructed in a certain method, you try your best to follow through with that method or that style. So some caveats before we delve into this. Number one, this video, is just general advice. It does not substitute what your residents and what your attendings ask of you. And then furthermore, in terms of advice for your specific surgical rotation, whether it be a subspecialty or general surgery, you should defer to what your senior medical students, like M4s, and trusted residents that you personally know tell you, because obviously every rotation is going to be different per institution and your experience is going to be different. So defer to their experience and their advice because they have actually lived through the specific rotation you have gone through, that you will be going through. And then number two, just it'll depend on the specific resident on your service and the specific service that you're on. For example, colorectal surgery will be different than cardiothoracic, then it'll be different than plastic surgery or vascular surgery. So this is general advice that doesn't take place of specific variants. So another key general principle is that you should never lie. Um, as a supervising resident, I would personally not overlook this if a medical student was discovered in a lie. Just always tell the truth. If you have a lecture at 2 o'clock, we're gonna believe you and you're gonna be sent for that lecture. Or if you're unfamiliar with something, you can just say you're unfamiliar with it, but that you're trying to read up on it. Um, the foundation of any sort of working relationship is trust. And medical students who are caught in a lie, it does affect their evaluation if it's given to the residents, or at the very least, it does leave a lasting negative impression that people remember. So do not lie. Always, always have integrity. Tell the truth. Don't lie about things. And then the other key principle is be humble. Don't hesitate to speak up if it's important or if it's relevant or you notice something safety wise or you have genuine questions. But be humble. You're there as a trainee. And remember that surgery rotations, or I mean, surgery teams are hierarchical. Um, so it goes the attending, the fellow, the chief resident, and down. You do not want to show up the residents or make them look bad. In general, you don't want to answer over the intern to score points. You're not going to get any points really. And then, um, the caveat to that is, of course, if you get directly called upon, you should answer the question. Um, and then, keep in mind there is a hierarchy. You don't want to be a medical student with poor emotional intelligence and kind of um, ostracize yourself from the team. You should, however, not hesitate to speak up for yourself. If you notice a factual error, a safety issue, you should speak up. You will be respected for this. And then if you don't know something, you should Don't hesitate to ask genuine questions. We can tell the difference when it's a forced question versus when it's a genuine question about the pathophysiology, the anatomy. Why did you do this? Why did you do that? Would it be correct to do this? Those questions are well regarded. Of course, do it, read the room, ask these questions in an appropriate moment. If the team is dealing with a pumper or a bleeder, or they look stressed, just wait a few minutes till that danger has subsided to ask the question. Let curiosity drive what you say, not performance. So my advice before the rotation starts, of course, talk to people who did that rotation, other medical students, residents that attendings. Try to get a lay of the land. What should you expect? What resources did they use? What tasks should you expect? What's the schedule like? What's the day off? What is your role? And then do some reconnaissance beforehand. Where's the building? Which room is it? Do I know the code? Do I know where their supplies are kept? These are things that if you do ahead of time will really make you stand out because it gives you a little bit more confidence. You're going to be there on time, and it's going to remove some of the barriers to momentum that are kind of subconscious. So in general, on a surgery rotation, you're going to be in a couple different places, and I'm going to break down this video and my advice to you based on which location you're on. And so we're going to break it down into the clinic, where you see patients in an outpatient setting. Number two, the floor, when patients have already been admitted to the hospital. Number three, pre-op, when a patient is about to go for surgery. Four, intra-op, when you are in the procedure itself. And five, post-op, after the patient is done with the surgery and about to go to the floor or the ICU. So number one, for the clinic, in general, it's better to assume that you should dress business casual with a white coat than to assume the opposite. A tie is even better. It makes you look sharp, it makes you look professional, and there is a role for that, especially in surgery. The caveat to this is unless the residents explicitly tell you, scrubs and a white coat or scrubs only, just defer to whatever they ask. But in general, if they don't give you direction on that, assume it's white coat and business casual. Number two, prep for your patients. Try to get assigned patients ahead of time and read up on them. Within reason, if it's possible for you. So why are they here? Why are they coming to clinic? What can I anticipate if the pathophysiology is a thyroid nodule? What are the next steps for workup? What are the next steps for management? What kind of questions are the patient going to ask? Can I propose to the attending a 10-second plan based on their chief complaint as to why they're going to be in clinic? I.e., what am I going to propose as the next step for this patient for this thyroid nodule? And then finally, be useful in clinic. Write notes accurately and quickly so that you can keep seeing more patients. And then, anything that the residents or attending or clinic staff need, don't hesitate to help them. Next is the floor. So you may be asked to pre-round, which is um, seeing the patients ahead of the team, earlier than the team, and then getting their vitals, seeing how they did overnight, assessing them, and then reporting to the team when they come in for rounds. This is kind of institution variable, so make sure you know if your team expects you to pre-round and be ready for that. And then this also applies to when you're on formal rounds with the residents. In general, I encourage you to carry these things in your white coat, and there will be specific differences based on the team and service you're on. You should have a pen light, trauma shears, 4x4 gauze, Kerlix, Ace wrap, which is a tan, stretchy bandage-like wrap, Zeroform, which is a bismuth impregnated dressing, um, and then saline flushes. The saline flushes are helpful in case you need to take down a dressing or kind of irrigate something real quick, like a wound. If you have these in your white coat or in a little baggie as you round with the team, they'll immediately like you right away because it speeds up rounds. You'll notice that people are trying to move fast through rounds, especially on a surgical service because you got to get to the OR. In general, you're gonna see pre-rounds at like 5 a.m., rounds at 6 a.m., and then OR by 7:30 a.m. In general, it'll vary on your service. But I encourage you to carry these things in your pocket or in your bag or in your white coat. And I've linked the pen light and shears that I personally liked throughout my surgery residency. Now, before you go to the OR, the night before, you should make sure you have clarified with the resident which OR cases you will be expected to be in the following day. Then you should read about them. If you have access to the EMR and the patient chart, you should investigate why the patient's getting the surgery, what sort of history they have, and what procedure they're going for. Once you know the procedure they're going for, you should basically get a quick overview of the procedure they're going for. Why is this operation being done? That's called the indication. What is the key anatomy of the procedure? And by key anatomy, I mean what are the landmarks that are going to guide you in this procedure? And then also what structures are the danger structures. Every surgery has some sort of critical anatomy that you're trying to avoid or identify. For example, if it's a thyroidectomy, they're going to definitely ask you about the recurrent laryngeal nerve and what happens if one is injured versus both are injured. Um, so every surgery kind of has these peculiarities that you should try to identify and um, know ahead of time before you go into the OR. I have linked below a surgical atlas called Zollinger's, which all general surgery residents, at least in my program, used. It's an excellent quick reference. However, it may be a little too in-depth for you. So if you can get your hands on it, um, I think it is helpful. Just skim through it. Think to yourself, why is this operation being done? What's the key anatomy? What are the pitfalls? What are the complications? Um, if you would like. I think if you're doing your sub eye in surgery, then Zollinger's is a worthy investment because you'll use it in your surgical career as well and surgical residency. But if you're a medical student, just and this is your routine surgical rotation, it's not critical. One book I do think was very, very helpful on my surgery rotation was Surgical Recall. I don't know how the authors uh, were able to figure this out, but quite literally, surgical recall almost verbatim identified maybe about 50% of the PIMP questions that I got in a given rotation. I don't know how they did it. And having read through it, the relevant sections the day before, I was able to nail those PIMP questions to a startling degree. So I do think surgical recall is a worthy investment if you are so motivated, and I linked it below. Now we go to the pre-op area. This is where the patient is being assessed by anesthesiology, by the pre-op nurses, the OR nurses, the surgeon, and this is where you should also do a few things. You should introduce yourself at this point to the patient first and foremost. Hello, my name is so and so. I'm one of the medical students on the surgical team. I'll be observing. It's very nice to meet you. Um, and then you want to, if you get the chance, identify yourself to the attending at this point, the resident, the OR nurse, um, just because this puts you on a good first impression. And if you are trying to make a good impression, in particular around surgery, this is a chance to be remembered and kind of stand out. Um, and then oftentimes what the resident will ask you to do at this point in pre-op is something called bird dogging, where the resident team will ask you to text them when the patient is actively being wheeled on the bed to the OR. Um, it may seem like a thankless task, but it is extremely helpful for the residents. because it's such a it alleviates a lot of the logistical burden, and it gives the residents a few extra minutes to keep working on uh, the stuff that the patients in the floor need, or seeing one more consult, and the residents will really appreciate it. So when you are intra-op, meaning when you are in the operating room, first and foremost, after you have introduced yourself either in the pre-op area or in, before the patient is actually intubated and anesthetized, you should again introduce yourself to um, the relevant staff, namely the attending, the resident, um, and the OR nurse. Uh, the first principle, though, after that is to do what you're told. Um, you know, for many of you, this might be your first surgical rotation. You won't really know the ebb and flow of the OR and what's expected, what's not expected. When in doubt, just do what you're told. Don't touch anything. Um, then also, the second principle is every interaction should be very respectful and professional, every single one. Um, People want you to be safe, they want you to learn, and they want you to be professional. Nobody expects you to do some above and the beyond stuff. Um, you know, just be a professional, just learn, soak up as much as you can, and do what you're told. Um, One of the trademark jobs of medical students on their surgery rotation is to cut suture. Um, so whenever you see, once they have some trust in you, you can often ask the surgical tech to give you the suture scissors, and then once the surgeon or the assistant has finished tying a knot, you can cut the tail of the suture that is just past the knot. But just always remember, don't cut the knot. Whatever you do, do not cut the knot, because that's gonna start annoying people, because they're gonna have to redo the suture. So if you are trying to impress in the OR, or this is your away rotation or sub internship, I really encourage you to learn the following fundamental surgical skills: two hand tie, one hand tie, instrument tie, simple interrupted sutures, running stitch, um, which is you can think of as like the baseball stitch, subcuticular running, which is when you bury the knot to hide it, um, hide the knots, and hide the suture. And then in general surgery, you're going to often be asked to close the port sites. So this is called a buried port site suture. And the key for that is throwing the suture deep to superficial, superficial to deep. Try looking up the other videos for these fundamental techniques. You will not master these in all likelihood, but it's very clear when someone has practiced this and is getting better at it throughout the rotation. It's very noticeable from the resident perspective. And then you also kind of don't want to be the person who constantly is asking the same question about the same technique that we've kind of gone over several times. You want to really kind of show some improvement if it matters to you, and um, and you're trying to make a good impression. So in the OR, undoubtedly there is going to come a moment where you break the sterile field. For example, your shoulder will bump into one of the light handles, or um, you accidentally touch your face with the sterile gloves. You know, don't be worried. That stuff happens, but again, the most important thing is the patient safety. So you should, if this happens, um, announce, what you contaminated. My elbow, I need a sterile sleeve, or my glove, I need a new glove. Just announce what you need, stop touching anything, freeze, and then move away from the field. Um, but of course, defer to whatever your instructions in the OR are. but in general, they'll ask you to move away from the field and they'll tell you what they want you to do. You might have to rescrub or you might have to get rid of the glove and they'll give you a new one. But just the most important thing to do is say, oh, I contaminated my so and so. I think I need a rescrub or get regowned or gloved, and they'll tell you what to do. So at the end of the case and going towards post-op, there's a lot of easy things you can do to make a good impression and help the team and speed things along. Um, Once the patient is extubated and put on the hospital bed, you can, after helping them move the patient over, you can get warm blankets. A hypothermic patient is at risk of coagulopathy, so warm blankets are kind of helpful. Um, you want to be another set of hands that helps with any sort of major movements that the patient needs, like from the OR bed to the hospital bed. Um, or repositioning the legs, or making sure the patient doesn't fall off the OR table. Any sort of little movements that you can help with, just be available to help with those. And then you want to go with them as they transport the patient to the PACU. You want to be ahead of the bed. You want to either help steer the bed or you want to open doors that are ahead of the patient so that they don't have to slow down. And then towards the end of the case, sometimes they'll ask you to grab the O2 tank. If you have become familiar with the location of these, that's fine as well. But again, defer to whatever they tell you to do in the OR. The other thing I want you to do, just for your own health, is if you're expected to round in a white coat, or if you have some extra pockets or a little bag, you can include gum, mint, and a little snack for yourself, just because you're going to be on your feet a lot in surgery. You're going to be running around. So I want you to stay hydrated. Make sure you're trying to get, 2-3 liters a day, if that's appropriate for you. But the point is to stay hydrated frequently throughout the day and get some food in you. It'll give you the energy to continue throughout the day. So, in terms of preparing for the shelf on your surgery rotation, and then what books you should have on you for the surgical rotation, I think that Surgical Recall is very helpful for nailing the PIMP questions in the OR or on the floor. It's very high yield, oddly. Um, Virgilio, the surgical case based approach, um, is excellent. I think it provides an excellent foundation in general surgery, which will be the majority of your shelf. Um, and then Pastana's surgical notes is very good because they do a good job of hitting you with key associations from each subspecialty. So they'll even give you key points about ophthalmology, urology, which do show up on the shelf. Um, and then Zollinger's Atlas, not essential. It may be too much at your level, but if you're very interested or really trying to understand the operation, it's a great resource. QBanks, I think UWorld and Amboss were excellent. Remember, on your surgical rotation, I really think it's your attitude that is the most important determinant of how the rotation goes. Be positive. Don't let people see you with a frowny face, looking exhausted or unhappy. Um, if making a good impression matters to you in surgery, then be positive and be on time. Keep your word. Be honest. Uh, do what's asked, and then do whatever else it takes to help the team speed things along, keep things moving, ease their burden. Practice your knots and stitches at home so that you can be facile in the OR. The more you show you can do, the more they will trust you and the more they will technically teach you, not just about the pathophysiology. Um, be humble. Don't be a performer. Ask genuine questions at appropriate times, and that will stand out. And then remember, never lie. Be honest, have integrity. As a physician, that is the bedrock of what we do. And then be affable, available, and able in that order. Good luck, you guys.